Thank you, sir. May I now request Dr. Rajeevalochana. She is a consultant nephrologist at Madras Medical Mission, Chennai, and she is going to enlighten us on essentials of post-transplant immunosuppression. Over to you, Dr. Rajeeva.
Thank you, Dr. Zishan and the Eurogroup and iTRUE for inviting me to this presentation. It's actually a real honor to share the stage with such eminent doctors. Are you able to see my presentation?
Yes, Rajiva. Can you make it full screen?
Yeah. So the topic given to me today is essentials of post-transplant immunosuppression. Hope I'll be able to do a justice to quite a vast topic of immunosuppression. So I've decided that my objectives of today's talk will be as to why we need to give immunosuppression at all. What are induction agents? What are maintenance immunosuppression agents? How do we monitor drugs? And in the situation of this current pandemic, is there any change we need to make at all when we are faced with COVID-19 or when we are doing a transplant during COVID-19? Now, yes, we do need immunosuppression because the graph is this one as a foreign object. So now what happens is it is construed as an antigen when and once that is done, the antigen presenting cells present it to the T cell. And once the T cell and the major histocompatibility complex or the HLA antigen is then presented to the antigen presenting cell, which is recognized by the T cell receptor and then leads to a host of cytokines and other co-stimulatory pathways being activated, which basically leads to rejection. Now, there are many types of rejection. I'm not going to go more in detail with that because I'm going to concentrate more on the immunosuppression. Now, coming to the first and probably one of a very comprehensive sort of a model is called as the three-signal model. This three-signal model basically tries to explain to us as to how an organ is actually recognized as foreign and then gets rejected later on. The types of rejection being like a hyperacute rejection, this occurs when there are preformed antibodies or anti-HLA antibodies present in the blood. To a large extent, I think with the current amount of testing that we do, the hyperacute rejection is fairly very, very low. Then we have the accelerated acute rejection, which can still occur, where you have either preformed as well as de novo anti-HLA antibodies. Then you have the acute rejection, which can either be a T cell mediated or a B cell mediated rejection. And then we have the chronic rejections, which do occur off and on. Now, coming to this three-cell signal model, I will just go to my next slide before that. This is a simple explanation of the three-signal model, where signal one is where the antigen gets present to the antigen presenting cells. Now, these antigen presenting cells can be dendritic cells or as well as macrophages, which will have the major histocompatibility complex on them. This will be presented to the T cell. So you have the CD4 as well as the CD8, CD4 being the helper T cells and the CD8 being the cytotoxic T cells. And once it is bound to the T cell, it then gets bound to the T cell receptor. Now, this is signal one, which is shown in this slide. So now this is the T cell. So where you have the antigen, which gets attached to the antigen presenting cell, along with the major histocompatibility complex or the HLA, which then goes and binds itself to the T cell receptor. Now, this is the signal one. Now, coming to the second signal, now this signal alone is not enough for the T cell activation to occur. Now, you need secondary signals which are required for both the activation and the proliferation of T cells. So you can have, so basically the CD4, for example, has CD28 molecules on its surface, which goes and binds to the B7, that is B7-1 and B7-2, which is CD80 and 81, which is present on the antigen presenting cells. Now, these are called as co-stimulatory cells. So now once the CD28 on the CD4 cells binds to the B7 molecules, it then activates the T cell further, and there is T cell activation and proliferation. Similarly, the CD8 cells have CD70 on their surface, which again binds to the 4,1-BB complex on the antigen presenting cells. Again, this is shown here where you have the signal 2. This is the CD80-86, which I was talking about, which is B71 and B72 on the antigen presenting cells, which binds to the CD28, which is present on the CD4 cells. And then it activates the pathway. Now coming to the signal 3. Now again, this alone again is not enough. So you first the antigen presenting cell, the MHC binds the T cell, binds the TCR. Then that has to actually activate the co-stimulatory pathway. And once the co-stimulatory pathway is activated, cytokines have to be released in order to cause the entire rejection. Now, these cytokines, for example, the CD4 cells can either become Th1 cells, they can either become Th2 cells, or they can become interleukin-17 cells, all according to the need. Now, there have been a variety of molecules which have been developed, and all these molecules try to attack one of these three signals at various levels. Now, coming to the array of immunosuppressants that we have, there are quite a bit of immunosuppressants. I think the main things that we will be talking about is steroids, azathioprine, cyclosporine, and tacrolimus, which is the calcineurin inhibitors. Then we have the mycophenolic acid, that is MMF. Then you have the Everolimus and Sirolimus group of agents. And you have a whole group of induction agents like anti-thymocyte globulin, Basiliximab, which is IL-2 receptor antagonist, and then you have the BELATACEPT, and which is again a maintenance immunosuppression molecule. Now, what are the goals of immunosuppression? One is definitely to prevent rejection. While preventing rejection, we have to make sure that we minimize the drug toxicity, reduce complications, the main complications being infections and malignancies, as well as definitely have a good graft and patient survival. Now, whenever we go into immunosuppression, there are three things that we do. One is induction, that is initially, then something to maintain the graft, that is a maintenance immunosuppression, and then the rescue therapies, where if the patient is actually rejected, we try to give them drugs to mitigate that effect. Now, coming to the induction therapy. Now, induction therapy is what we give early on, that is just prior to the transplant or on the day of the transplant, to minimize the risk of acute rejection in the initial days, weeks, and months. There is a need for strong initial immunosuppression to deplete or modulate the very good T cell responses at the time of antigen presentation. The antibody induction decreases the rejection rates and improves long-term patient and graft survival outcomes versus no induction. Now, when do we use this induction therapy? When we know that there is an immunologically high-risk patient, for example, someone who has a positive cross-match, has a preformed HLA antibody which has been documented, cadaveric transplants where the cold ischemia time is more, the younger recipient age where their immunity in general is pretty high, older donor age where African American ethnicity, high PRAs, presence of DSAs, ABO incompatibility, where we actually use a little more of induction, where we have to do little extra removal of antibodies with plasmapheresis and rituximab, delayed graft function, and cold ischemia time more than 24 hours. Now, these set categories of patients are considered immunological high risk. And again, the organ transplanted also is important because the degree of immunogenicity varies by the lymphoid tissue around the organ. So intestine more than pancreas, more than heart, lung, more than kidney, more than liver. So basically in the order of how vulnerable they are to the rejection. So induction therapy is something that we routinely use. And coming to the agents that we currently have, so it all started with, I think, OKT3, which was way before in 1997. A highly good agent, which basically is a MAB. It is against the CD3 cells. Now, OKT3 went kind of out of use because of its severe reactions which it had. Currently, the main induction agents that we use are thymoglobulin, which is a depleting agent, anti-thymocyte globulin, and Alemtuzumab, which is an anti-CD52 antibody. Now, the non-depleting agents which are there are Basiliximab and Tacrolimus. Basiliximab, both Basiliximab as well as ATG are pretty much widely used. This is the timeline of when it came, and currently we have these two agents pretty widely available in the market. Now, coming to the lymphocytes, I think anti-thymocyte globulin has a very good effect on depleting antibodies, followed by Alemtuzumab. Basiliximab, yes, to some extent, but it is a non-depleting antibody. Now, coming to ATG, it's basically a polyclonal anti-thymocyte antibody. So what it does is it interacts with the lymphocyte surface antigens, which include CD2, CD3, CD4, etc., and depletes the number of circulating T cells. It can be derived from the rabbit or the horse. RATG, that is rabbit ATG, is widely used. It can cause infusion reactions and cytokine release syndromes, which can occur at any time during the infusion. We have to pre-treat with steroids, acetaminophen and diphenhydramine. There's a frequent vital monitoring can occur. We have to look out for hypotension during the infusion reaction. Now, common adverse effects include leukopenia, which we see quite commonly when we give ATGs, and thrombocytopenia, a serum sickness-like syndrome. There is an increased risk of infection, both short-term as well as immediate long-term with ATG. And there may be an increased risk of thrombosis and local tissue reactions when we use ATG. Now, the dosing of rapid ATG is around 3 to 6 milligram per kg over 3 to 5 divided doses. Now, this, I think, basically has to be kind of interpreted according to the individualized center, the individualized patient, as well as the region where we are from. Working in the West, I have seen higher amounts of ATG being used, whereas in India, we do see that not many patients tolerate very high doses of ATG. They do end up with severe infection. So we do need to use it with caution and individualize it according to the patient profile. Now, the equine ATG is around 10 to 15 milligram per kg, and both have been used, whereas our ATG is more commonly used in kidney transplantation. Coming to Basiliximab, it is a chimeric monoclonal antibody, which basically inhibits T cell activation by binding to the IL-2 receptor, which is CD25. Unlike ATG, Basiliximab is well tolerated without any significant risk of infusion-related reactions. If an anaphylactic reaction occurs, the infusions should be stopped immediately with no rechallenge. Typically, and it's pretty much widely the same dose, where we administer 2 doses, that is 20 milligram on day 0 and day 4. The other thing is Alemtuzumab, also called as Campath-1H, which is a recombinant humanized anti-CD52 monoclonal antibody, which binds to and depletes both B and T lymphocytes. It has very similar adverse reactions to ATG, can cause infusion-related reactions, hypotension, rigors, fever, and shortness of breath. Cytopenias are pretty common. It does increase the risk of infections and malignancies. It is a single dose, which is a 30 milligram dose over 2 hours with good pre-medication as well as vital monitoring. Now, this is a summary of all the 4 drugs, that is Basiliximab, ATG. It's here, this is from up to date, where 1.5 milligram per kg over 3 to 14 days. Personally, as a group, we have never used for that many days. We do use lower doses of ATG, even in highly immunological risk transplants. So then you have the equine ATG, which can cause, again, serum sickness-like syndromes, and Alemtuzumab, which is anti-CD52, which is, again, a single dose with fairly similar side effects to ATG. So basically, when don't we use induction agent at all? When there is a white double haplotype matched twin transplant which is done, which is fairly rare, which is one of the first transplants which was done, then there is no need for an induction agent when there is 0 HLA mismatch. The other thing is when somebody has already had another transplant, another organ transplant like a heart or a lung, and you're then putting in a kidney, you may not need an induction agent because they're already on immunosuppression, and it may increase the risk of leukopenias and infections. But by far, I think most of us do use some sort of an induction agent, with a lot of us preferring ATG over Basiliximab, especially in the higher risk groups, as I've already told you. Now, what is the difference between rabbit ATG versus no induction versus ADGAM, which is the equine ATG, versus Basiliximab? Basically, all the studies which have been done, the major ones have been done in the deceased donor groups. There are some observational studies which have been done in the living donor transplant groups and low risk groups. And across the group, there is a lower risk of acute rejection in the first 6 months up to the 5-year mark, both in the low risk as well as the high risk groups. But I think all the studies have shown that RATG does cause a bit of prolonged lymphopenia. There's a risk of higher risk of infections, especially CMVs, and there is not much of a difference in the graft and patient survival at 1 and 5 years. As I've already told you, any 2 haplotype white person with living related donor kidneys and where there's 0 HLA mismatch, and the recipients of a kidney transplant who have another functioning solid organ transplant. Now, this again has to be, I think, with more and more understanding of anti-HLA antibodies, non-HLA antibodies, as well as eplet mismatches. I think it's very important to kind of go through their immunological workup in detail before deciding what sort of induction therapy you want to go for. So I think as far as the KDIGO 2009 guidelines are concerned, it says that in high-risk group, prefer ATG. In low-risk groups, prefer IL-2 receptor antagonist, which is Basiliximab. Now, coming to the maintenance therapies, now once you have induced, that does not last forever. So we need to maintain the patient on a good amount of immunosuppression to prevent any of those 3 signals from getting activated. Now, coming to maintenance therapy, generally we give a triple drug regimen, which have complementary effects, maximize efficacy with lower side effects. Now, the triple drug regimen traditionally generally have a CNI, which is a calcineurin inhibitor. We have an anti-proliferative agent in the form of mycophenolate mofetil or azathioprine, and steroids. Now, steroids in general have a multimodal mechanism of action. It has a role in induction, it has a role in maintenance, and in the treatment of rejection. Traditionally, I think around 15 milligram per kg can be used initially just at the time of induction, followed by 0.5 to 1 milligram per kg per day, which can be rapidly tapered to around 5 milligram per 1 to 1.5 months. That is about 6 weeks, which again has to come to around 0.05 milligram per kg per day by 6 to 12 months. Now, this is basically a basic guideline issued by the KDIGO. This basically varies quite a bit between centers and individual physicians. And basic idea is try to minimize the steroids as much as possible to avoid their side effects. Steroid-free regimens have been traditionally in use. Not recently, basically what they say is if you want to minimize steroids, you want to go on a steroid-free regimen, try to cut it down within 1 week and stop it, and then go on to a CNI with MMF. There is a higher risk of rejection in these regimens, and definitely depends upon the patient risk profile. Now, as I told you, the steroids mechanism of action can be multimodal. It blocks the antigen-presenting cells. It blocks the B cells. It blocks the T cells, as well as it blocks the cytokine production. It is really a double-edged sword. We see a high degree of hypertension, where there is increased sensitivity of the vessels. We see almost 15% of our patients developing hypertension post steroids. Know that a great degree of patients develop new onset diabetes or post-transplant diabetes mellitus. Dyslipidemia, we don't know the exact incidence, but definitely it is high. Cataracts, glaucoma over time, bone disorders, peripheral fractures, and avascular necrosis of bone are extremely common in patients on steroids. And of course, infections, which I haven't mentioned because I think all immunosuppressive agents and with the increased dose of steroids, especially after this pandemic, I think we realize more and more how much of infections we are currently facing. The calcineurin inhibitors sort of revolutionized our transplant medicine. It's a backbone of immunosuppression therapy. 1983, cyclosporine was got. 1990s, tacrolimus was approved. Both CNIs have pharmacokinetic variability, a very narrow therapeutic ratio, and the efficacy corresponds to blood levels. Now, how does it act? Both cyclosporine as well as tacrolimus basically inhibits calcineurin. Cyclosporin binds to cyclophilins, tacrolimus binds to FK binding protein FK506, and then it binds it binds to calcineurin and prevents the IL-2 formation or the cytokine production. Cyclosporin again derived from a fungus. There are multiple formulations which are oil-based and microemulsion based. We generally prefer microemulsion based. We do have IV formulations of cyclosporin. The tacrolimus is a macrolide antibiotic from the streptosuccubenins, also available as once daily formulations, which reduces our issues with compliance. Now, coming to the dosing, generally cyclosporin is given in 2 divided doses, 12 hours apart, around 4 to 6 milligram per kg to achieve trough levels. These numbers generally very difficult to remember. Generally keep referring to it. Around 250 to 350 nanogram per ml in the first 6 months, a little lesser in 6 to 12 months, and more than 1 year. We can give IV infusions at 1/3 of the daily oral dose. Tacrolimus is fairly easier to remember. It's 0.1 milligram per kg per day in 2 divided doses if you're giving the short-acting tacrolimus, and 0.15 milligram per kg once daily tacrolimus. When we are using tacrolimus, it is important to remember that in the first 1 month of transplant, we try to keep it between 8 to 10 nanogram per ml, whereas in the first 6 months of transplant, we try to keep it between 6 to 8, and after 6 months to 1 year, we try to keep it between 4 to 6 nanogram per ml. So very high tacrolimus levels, we generally don't do it. So basically, kidney transplants, generally we try to keep it at around 7 in the first 1 year, first 6 months, and then kind of slowly taper it off. Now, what are the CNIs? Generally can have a fair amount of toxicity and a slightly different profile between cyclosporin and tacrolimus. The nephrotoxicity is more with cyclosporin, especially since it's been used longer than tacrolimus. Hypertension more with cyclosporin, NODAT more with tacrolimus. Dyslipidemias, hyperuricemia slightly more with cyclosporin. The metabolic side effects almost equal between the two. The cosmetic side effects like hypertrichosis and gingival hyperplasia more with cyclosporin, and alopecia more with tacrolimus. Now, both of these get metabolized by the CYP450-3A4 systems, and therefore anything which induces the system will decrease the levels, like rifampicin, phenytoin, St. John's wort, whereas things which basically inhibit the CYP3A4 systems will increase the levels. It's a good idea to go through these tables pretty frequently so that we understand what's exactly going on. Now, coming to the positive thing of tacrolimus versus cyclosporin. See, head-to-head comparisons have been done in the ELITE Symphony trial, where low-dose and high-dose cyclosporin formulations were compared with tacrolimus, and tacrolimus showed a lower acute rejection risk with lesser hypertension and lesser cosmetic side effects. But supposedly slightly cyclosporin is better in HCV infections. I think that is no more there because HCV has very good treatment and where they become negative, and there is a lower incidence of diabetes. And there was a recent paper in AJT around a year ago, which where they did a randomized control trial where they shifted over from tacro to cyclosporin in patients at risk for NODAT and found a lower risk of NODAT in these patients. Now you have the tacrolimus. The negative side effects include the neurological side effects as well as higher incidence of diabetes, whereas the cyclosporin, higher nephrotoxicity and higher risk of cosmetic changes, which are seen in this one. Now, CNI nephrotoxicity, as we're all, urologists and nephrologists in this panel, patients treated with CNIs, cyclosporine, tacrolimus are at higher risk of developing AKI as well as CKD. Concomitant use of nephrotoxic agents, salt depletion, diuretic usages, and drugs that actually interfere with the P450 and P glycoprotein systems can cause CNI nephrotoxicity. We can have acute hemodynamic toxicity, chronic CNI toxicity, as well as thrombotic microangiopathy in rare cases. Now, this is a small picture which shows vacuolization, which is these small vacuoles which are formed in the proximal tubular cells due to cyclosporine nephrotoxicity, and striped fibrosis, where there are areas of fibrosis by areas of normal interstitium, which is seen in chronic CNI toxicity. Now, mycophenolic acid is a prodrug which is hydrolyzed into mycophenolic MMF active form. It inhibits the IMP dehydrogenase and therefore inhibits the de novo purine synthesis, mainly active in signal 3 of the pathway. MPA selectively inhibits the lymphocyte proliferation and due to the inability to utilize the salvage pathway of purine synthesis. Now, mycophenolate versus mycophenolic acid. Now, mycophenolate is 720 milligram twice a day. It's a sodium salt. Its active moiety is actually mycophenolate. It is an entry-coated tablet, and there's a delayed release, and it releases in the small intestine. Whereas mycophenolate mofetil is a 500 milligram tablet. We generally give 1 gram twice a day. The prodrug is hydroxyethyl morpholine ester. Active moiety is again mycophenolate. Immediate release occurs in the stomach. Now, MMF toxicity is mainly GI toxicity. Sometimes we see entire areas of the colon being sloughed off. The cytopenias are fairly common. First trimester pregnancy loss and congenital malformations are very common. Therefore, in patients who have a good graft function 1 year post-transplant and the female wishes to become pregnant, it has to be counseled and stopped at least 6 weeks before the planned pregnancy and has to be switched over to azathioprine before we plan the pregnancy. Now, coming to azathioprine, it's a prodrug hydrolyzed into 6-MP, which is mercaptopurine. It's an alternative to more teratogenic immunosuppressants if the patient becomes pregnant or if the patient has MMF-related toxicity. We have to remember that azathioprine was widely used, and many of the nephrologists, especially in India, still use azathioprine. Patients do fairly well on it. There was one head-to-head trial where they compared MMF with azathioprine, where they found MMF to be better in terms of preventing acute and chronic rejection. Azathioprine is mainly problems are bone marrow suppression, hepatitis, pancreatitis, and alopecia. Bone marrow suppression, if it occurs, it's basically dependent on the enzyme TMPT. And if the TMPT enzyme levels are low, then the amount of suppression is more. Therefore, if they do develop such a toxicity, it is good to kind of see the enzyme level. Dosing is generally 1.5 to 3 milligram per kg per day and keep the WBC count more than 3000. Levels generally need not be monitored, and it is a cheaper version to the CNIs. Coming to the mTOR inhibitors, which is a proliferation signal inhibitor, it is an alternative to CNI. It's anti-angiogenic, it's anti-proliferative. The two drugs which are available are Sirolimus and Everolimus. Basically, this basically inhibits the mTOR pathway, which is again the second signal number 2. As an alternative to CNIs, generally we don't use it initially, at least very initially post-transplant, because one, it can lead to delayed healing, it can lead to lymphoseals, as well as the CNI withdrawal in long-term post-transplant. There is worsened graft survival and DSA development. Definitely it's anti-angiogenic, as we have seen Sirolimus coated stents in the cardiac setting. It is anti-proliferative, especially if somebody develops a malignancy, especially skin malignancies. It may be worthwhile shifting over to mTOR inhibitors. So what is the difference between Everolimus and Sirolimus? The oral bioavailability is slightly higher. We generally target levels between 8 to 12 nanogram per ml. We can give concomitant CNIs when we give Everolimus, and we have a variety of dosages of the tablet which are available. Now, common side effects are hypercholesteremia, hypertriglyceridemia. It's very important that when we are using it in concomitance with CNIs, it can cause thrombotic microangiopathies. Very commonly, it causes mouth ulcers and wound healing. I just wanted to mention that proteinuria is fairly common when we use these anti-proliferative agents. And it's important that if somebody has proteinuria more than 1 gram, it's important to kind of make sure that we avoid using these drugs. Hepatic artery thrombosis in a liver transplant patient and bronchial anastomotic dehiscence has been seen with Sirolimus. They have very similar drug interactions like CNIs and also require therapeutic drug monitoring. Now we have the other drug, which is BELATACEPT, which is basically a co-stimulatory blockade. It's a second generation drug after abatacept. It basically blocks the CD80, that is B7 group of molecules. It is an IV immunosuppressant, one of the first IV immunosuppressant which can be used. Generally, there is no therapeutic drug level monitoring which is required. However, in very high risk groups, there may be higher acute cellular rejections. There is comparable graft survival and superior renal function. So both Sirolimus, Everolimus, and BELATACEPT can be used whenever we are facing CNI toxicity. It's contraindicated in EBV due to the risk of post-transplant lymphoproliferative disorders. Dosing is day 1 and day 5. We give 2 doses, that is 10 milligram per kg. Then at the second week and 4th week, we give 10 milligram per kg. And then at the end of 8th and 12th week after transplantation, we give 10 milligram per kg. After that, at the end of week 16, that is almost 2 months post-transplant, we give it every month. So especially in patients who are not compliant with the drug regimen, it's nice to use BELATACEPT. Use it with caution because the risk of acute cellular rejections may be more. Definitely all this, so generally what we do is we give an induction agent, then the very next day we start a CNI oral steroids as well as MMF, that is an anti-proliferative agent, and then monitor the levels and see how it goes. But if there is a failing allograft, we need to modify the immunosuppression. So basically, if there's a failing allograft, we can minimize the anti-proliferative agent and CNIs a little bit because we don't want them to end up in infection. At the same time, keeping in mind that this patient may require another transplant and we want to reduce the amount of sensitization. Second is rejection. Of course, at this point, we can increase the baseline maintenance immunosuppression and depending upon the type of rejection we treat. Recurrent disease may require some amount of modification. Malignancy, we may have to stop a couple of the drugs. We may have to switch over the drugs. Infections, yes, we generally what happens is in severe infections, we do stop the anti-proliferative agent and then slowly come down on the immunosuppression depending upon the infection. It's always the dictum that the patient is more important than the graft, and in severe infections, we may have to come down drastically on the immunosuppression to save a patient's life. Surgeries and pregnancy. Pregnancy especially is very important because generally it should be a properly counseled pregnancy in these patients who have already received a transplant. Generally it is done. It's I think that's a separate topic altogether, but basically it is important to do a pre-pregnancy counseling as well as try to stop the MMF, switch over to azathioprine, make sure that the graft function is normal, and then kind of go in for a pregnancy. And non-compliance, we have once daily Tacrolimus regimens. We have regimens like BELATACEPT, which can help us in overcoming non-compliance. Coming to COVID-19 and immunosuppression, I think once a transplant patient becomes infected with COVID-19, I think it's pretty much individualized according to the severity of the disease. In mild disease, I don't think there is any need to reduce the immunosuppression. In moderate disease, I think most of us do come down on the anti-proliferative agent or stop it for a short while. And in severe disease, of course, we may have to come down on it significantly. Or at the same time, we have to remember that a rejection episode at this point can be fairly detrimental and harmful because we will have to use more immunosuppression at that point, and a bad kidney function worsens the risk of COVID-related deaths. As such, there is not much of a change in the induction and maintenance immunosuppression protocols at this point. We do rigidly kind of monitor whether a patient has any symptoms related to COVID-19, whether they have been tested or not. And of course, some of our centers, I think, do perform CT scans to make sure there is no evidence of COVID-19 active infection. We have to vaccinate our pre-transplant patients against COVID-19 at least 2 weeks before. And if you have not done, then wait for 1 month post-transplant according to the recently issued guidelines. I would suggest reading the KDIGO 2009 guidelines. Little old, but fairly covers most of the immunosuppression. We have a more recent 2020 guidelines, but that basically covers only the workup of the patient. The kidney transplantation in adults in up-to-date, both the induction as well as maintenance immunosuppressive therapy is very, very much in detail. It's a good to read with all the trials being given. Peter Morris, there is a chapter dedicated to every immunosuppressive agent, and a very nice review of and meta-analysis by Sejev on the early changes in kidney transplant immunosuppression regimens during the COVID-19. Many publications from IKDRC, I think, in regards to COVID-19 and transplantation is a good read to follow. And with this is the place I work. Thank you so much for this opportunity. It's been a pleasure.